Hello everyone, I am Dr. Snehata Verma, reader from the School of Dental Sciences, BBD University. In today's video, we are going to talk about few interceptive measures from the topic Interceptive Orthodontics. We all know about the various disciplines of orthodontics that includes preventive orthodontics, interceptive orthodontics, corrective orthodontics, and the surgical orthodontics. The interceptive orthodontics can be defined as that phase of science and art of orthodontics employed to recognize and eliminate potential irregularities and malpositions in dentofacial complex. In this, corrective measures may be necessary to prevent a potential irregularity from progressing into a more severe malocclusion. Various interceptive measures includes correction of anterior and posterior crossbites, removal of soft or hard tissue impediments to path of the eruption, interception of developing skeletal malocclusions, elimination of deleterious oral habits, muscle exercises, space regaining, and the serial extraction procedure. The first three measures we have covered in a previous video lecture. In this lecture, we are going to cover up the oral habits elimination, muscle exercises, and the space regaining procedures. So, coming to the habit can be defined as the tendency towards an act that has become a repeated performance, relatively fixed, consistent, and easy to perform by an individual. These oral habits are learned patterns of muscular contractions. It is an autonomous response to a situation that is acquired normally as a result of repetition and learning. Strictly applicable only to motor response, and they are of complex nature. Abnormal oral habits in children interfere with the regular pattern of facial growth and have a definite bearing on the development of occlusion. So, a thorough knowledge about all deleterious oral habits is mandatory to perform interceptive orthodontic procedures. Interception of mouth breathing habit. So, who are the mouth breathers? Mouth breathers are those children who breathe orally even in relaxed and restful conditions. It may be due to learned habit or due to obstructed airway passage. The mode of respiration influences the posture of the jaw, the tongue, and to a lesser extent, the head also. Mouth breathing has been attributed as one of the possible etiologic factors for malocclusion. Hence, a thorough clinical and radiographic examination of the nasal airway passage should be done. Correction should be aimed firstly to remove the etiology that may be anatomical or functional. It is very important to determine type and degree of mouth breathing, whether habitual or obstructive, and whether it's a complete or partial type. In case if there is any anatomical obstruction, that should be corrected first with the help of otorhinolaryngologist before attempting to correct the mouth breathing through interceptive orthodontic procedures. For the correction of mouth breathing that is habitual in nature, the oral screen is appliance of choice. It can be given to intercept the mouth breathing. In true habitual mouth breathers, oral screen with several holes can be used, that we can see in this picture. And the gradual reduction in number of holes will slowly alters the patient's breathing habit from oral to nasal. Second maneuver we can use is the rapid maxillary expansion, which is useful in decreasing the airway resistance and increasing nasal airflow. It is particularly useful in patients with narrow maxillary arch. Next, deleterious habit can be a thumb, finger sucking, or associated habits. Hence, finger sucking is one of the factors in deformation of the teeth and supporting structures, but it is just that only one factor in a syndrome that consists of various admixtures of tongue thirst, abnormal deglutition, lip biting, hyperactive mentalis muscle, hypoactive upper lip muscles, and probably hyperactive buccinator activity as well. So the treatment for these sucking habits should start from 4th to 6th years, and we have 4 different approaches for this. First one is the counseling, reminder therapy, reward system, or some adjunctive therapies. Rationale is for the emotional significance of the habit, psychological status of child, age of the patient should be considered, and status of occlusion should be kept in mind. Conservative management will include we can ask the patient to run the tongue rhythmically back and forth over the lips for 5 to 10 minutes before retiring. Warm milk or soft music before retiring will also reduce the desire to suck. Definitive management for these sucking habits will include the placement of some habit-breaking appliances. Chemical treatment may be done, but it is the least effective. And for this measure, we can use some bitter or sour chemical over the finger that will be break the habit. And these materials includes foul-smelling quinine, asphodine, pepper, castor oil, or fumite, etc. Mechanical or reminder therapy can be used for the correction of these sucking habits. So for the extraoral approach, reminder therapy includes the mechanical restraint to the hand and digits. That includes adhesive bandage, or the thumb or finger can be covered with cloths. Thumb guards, acrylic guards can be used to restrict the habit. Among the reminder therapy, some intraoral appliances can also be advised. Definitive management includes placement of habit-breaking appliance like triple loop corrector that was introduced by Barber. It has a modified palatal arch and it has 3 loops similar to the TPA. Bluegrass appliance is also used, that can be given between the 7 to 13 years. And here is a Teflon roller type of appliance that should be placed 3 to 6 months wear to break the habit. Fixed intraoral anti-thumb sucking appliance is a design which attached to the upper teeth by means of bands fitted to the primary second molar or permanent first molar. A lingual arch from the base of the appliance to which are added interlacing wires in the anterior part of the hard palate here. It works by preventing the patient from putting the thumb in contact with the palatal surface, thereby robbing the pleasure of sucking. Adjunctive therapy may include the placement of the palatal crisp. It breaks the suction and force of an anterior segment. It also acts as a reminder therapy and makes the habit non-pleasurable for the child. Hair rakes can be used, but they are not of much use and because of irritability and night tremor. Coming to the next very deleterious habit, tongue thrusting. It is an oral habit pattern related to persistence of an infantile swallow pattern during childhood and adolescence, and thereby produces an open bite and protrusion of the anterior tooth segment. Snyder defined it as a forward placement of the tongue between the anterior teeth and against a lower lip during swallowing. Usually 500 to 1000 times a day, the tongue thrusts forward to accentuate the open bite or maxillary incisor protrusion. For the correction of tongue thrusting habit, we have some myofunctional exercises which helps the occlusion to adapt to function, and child is trained to develop a new swallowing pattern and through this altered tongue and lip function correct a malocclusion or prevent relapse in orthodontically treated cases. Muscle exercises include In this, the patient can be guided regarding the correct posture of the tongue during swallowing by various exercises. In Barnett's tongue positioning exercise, the child is asked to place the tip of the tongue on the incisal papilla and asked to swallow. In elastic and sugarless fruit drop exercise, here these sugarless fruit drop can be held by the tip against the palate on the rugi area during the practice. 4S exercise includes identifying the spot, salivating, squeezing, and swallowing. Some other exercises include where the child is asked to perform a series of exercises such as whistling, reciting the count from 60 to 69, gargling, yawning, etc. to tone the respective muscles. For the tongue thrusting habits, appliance therapy will include some removable appliances like Hawley's appliance with a modification of active labial bow and addition of the palatal grip. A variation of the finger sucking appliances tends to force the tongue toward and backward during swallowing. Spurs bend down to form a sort of picket fence behind the lower incisors during full occlusal contact of the posterior teeth. Oral screen and vestibular screen can also be tried. A bluegrass appliance, which was introduced by Bruce Haskell, it is an appliance that can be given to guide the tongue into a new position. The patient is asked to roll this Teflon roller through the tongue so that the tongue is away from the dentition and thereby not getting the protrusion of the anterior dentition. Palatal crib appliance will help in correction of tongue thrusting by restricting the tongue in the posterior space posterior to the palatal crib. Here, the gauze wire 19 gauge wire is as a base bar is used for making the crib. One end is soldered to the base bar in the area of the canine region here. A 3-4 V-shaped projections are made, extending them downward to a point just behind the cingulum of mandibular incisors when the casts are occluded and are soldered. That is, the height of the cribs should not extend beyond the mandibular cingulum area. If bilateral narrowing exists posteriorly, expansion may be placed in the lingual wire. Another habit we can include is the bruxism. It is habitual non-functional contact of the teeth, including clenching, bracing, gnashing, or grinding of the teeth. May be nocturnal or diurnal parafunctional activity. This term is used in association with subconscious nocturnal grinding characterized by rhythmic patterns of masseter EMG activity. Term bruxomania refers to parafunctional activity during daytime. Patients having habit of bruxism usually present muscle and TMJ pain with generalized attrition of the dentition. Primary cause of bruxism is emotional and psychological factors and should be addressed first with appropriate psychotherapy. Flexible acrylic or plastic occlusal wafers, that is night guard or occlusal splint, can be given to prevent the attrition of the teeth. This type of appliance is given for the treatment of bruxism. Nail biting is another deleterious habit, also known as onychophasia, is a common distressing habit both in adults and children. And due to this, local tooth irregularities such as rotation, wear of incisal edges, and minor crowding can occur as a result of this habit due to significant pressure created during nail biting. This figure shows the wear of incisal edge due to significant nail biting habit. Habit can be controlled by positive reinforcement and behavioral therapy. Lip biting and sucking. Lip sucking habit is a compensatory activity that results from an excessive overjet and relative difficulty of closing the lips properly during the deglutition. It is much easier for the child to cushion the lip to the lingual side of the maxillary incisors. To achieve this, he calls on the mentalis muscle, which in effect extends the lower lip upward. Maxillary incisors are forced upward and forward into a protrusive relationship. The mentolabial sulcus or suprasymphyseal cleft becomes accentuated due to this habit. A marked flattening and crowding occurs in lower anterior segment due to lower lip sucking. Abnormal swallowing habits with associated hyperactive mentalis muscle activity can also be present. Here, the appliance should be worn for 8 to 9 months. Abnormal activity is almost always associated with class 2 division 1 malocclusion and open bite problems. Elimination of the malocclusion usually restores the normal muscle function, but if the posterior occlusion is normal or has been corrected by prior orthodontic therapy and there is a still lip sucking tendency, a lip appliance may be necessary. If the lip trap or if the lip habit is primarily due to neuromuscular tic or a nervous habit, lip appliance will be effective. These lip habits, due to the presence of lip trap, are not self-correcting. They become deleterious with age. So primarily, habit should be corrected by the correction of digit sucking followed by habit reminder appliances. Chemical reminders can be given. Correction of malocclusion with the corrective orthodontic therapy for the class 2 division 1 malocclusion should be appropriate for this correction of this habit. Appliance therapy for lip habits will include the oral shield in the class 1 malocclusion, and it will increase the lip tonus by the lip exercises. Lip bumper is another appliance which prohibits excessive force on the mandibular incisors, and it will reposition the lower lip away from the upper incisors. Coming to the muscle exercises, as an interceptive procedure, the dental tissues are blanketed from all directions by muscles. Normal occlusal development depends upon the presence of normal orofacial muscle function. Muscle exercises will help in improving aberrant muscle function. For the masseter muscle, exercise is to involve the clenching of teeth by the patient while counting to 10. The patient is asked to repeat this for some time. For the lips and cheeks, that is circumoral muscles, stretching of the upper lip to maintain lip seal is useful in patients having short hypotonic lips. To aid in stretching, the patient is asked to hold a piece of paper between the lips. Patient can be asked to stretch the upper lip in a downward direction towards the chin. And another exercise can include that holding and pumping of water back and forth behind the lips. Massaging of the lips can also help in the correction of these muscle problems. Button pull exercise is exercise where a button of 11 by 2 inch diameter is taken and a thread is passed through the buttonhole, and the patient is asked to place the button behind the lip and pull the thread while restricting it from being pulled out by using lip pressure. Another exercise is the tug of war exercise for the muscles, which involves 2 buttons with one placed behind the lips while the other button held by another person to pull the thread, and again the person has to restrict it from being pulled out by using the lip pressure. Tongue exercises will include one elastic swallow or tongue and the tongue holder exercise. In one elastic swallow, here the exercise is used for the correction of improper positioning of the tongue. A 5 by 16 inch intraoral elastic is placed on the tip of the tongue and the patient is asked to raise the tongue. and hold the elastic against the rugy area and try to swallow. And this exercise will help the tongue to get a new position, which is new normal for the patient. Next exercise is the tongue hold exercise, where a 5 by 16 inch elastic is positioned over the tongue in a designated spot for a prescribed period of time with lips closed. The patient is then asked to swallow with elastic in place and lips apart. Two elastic swallow exercise will include here same two 5 by 16 inch elastics is placed over the tongue, one at the midline and the other on the tip, and the patient is asked to swallow with elastic in position. The hold pull exercise, here the tip of the tongue and midpoint are made to contact the palate and the mandible is gradually opened. This exercise helps in stretching the lingual frenum. Some tooth eruption problems which may be intercepted at a proper time to make the malocclusion, to restrain the malocclusion to become more severe. These are we have to look after for the over retained primary teeth, because permanent teeth should replace its primary predecessor when approximately 3/4 of the root of the permanent tooth has formed. Space where the resorption of the primary root is or is not the point of spontaneous exfoliation. If portion of permanent crown is visible and primary tooth is mobile, wiggle the tooth out. If primary tooth does not exfoliate, extraction of the primary tooth is mandatory at this point. In this primary dentation, the spur on the lingual arch can be used to maintain a correct midline when a primary canine is lost prematurely. In case of impaction, the canine was exposed surgically and attachment was bound to this and with a precious metal chain, and the crown is pulled towards the occlusal line. Here is a case of a picture of developing crossbite which can be corrected or intercepted with a band with an attachment having a buccal tube cemented on the primary second molar. A large omega shaped loop and a helical loop are bent distal to the primary molar. The helical loop is compressed during bonding to the occlusal surface of the permanent first molar and activated by opening this omega loop. This omega loop will push the erupting first molar towards a lingual direction and prevent it from the crossbite. Supernumerary tooth may cause some form of malocclusion, and they can cause crowding or spacing. Most common location of the supernumerary teeth is the anterior maxillary segment. Tooth that is nearest to the ultimate final position should be retained, and other supernumerary tooth can be extracted as soon as possible without harming the developing normal teeth. Delayed incisor eruption. When the incisors have failed to erupt more than a year past the normal eruption time and adjacent teeth are erupted, this situation will require the timely intervention by the orthodontic means. Treatment can be, if there is enough space available for the incisor to erupt, then tooth is likely to erupt without orthodontic traction and surgical uncovering is warranted. If tooth is deeply placed, overlying and adjacent tissue should be repositioned apically to expose the crown, and metal chain is attached to the bracket or button and extended out of the tissue so traction can be applied to the tooth. Another situation, if space is not adequate for the eruption of the incisors, then preoperative space opening should be accomplished, and after creation of the space, the flap has been released on both the sides repositioned apically and sutured in place while leaving the adequate exposed tooth surface that can be seen in this picture. 1 week post-surgery, the tissue is healing well, and finally, when the tooth erupts to some extent, the appliance in place for the final positioning of the impacted incisor. Ankylosed primary teeth, when they should be considered if primary teeth fails to resolve or are retained by a bony attachment in the cervical region, constitute a potential alignment problem for the permanent teeth. There may be two situations. We can maintain the ankylosed primary molar until an interference with eruption or drift of other teeth begins to occur, and then extracting it and placing a lingual arch. And if there is a situation when there is no permanent successor, it should be extracted. This radiograph demonstrates both anterior and posterior teeth tipping over the ankylosed primary molar. The ankylosed teeth should be removed if significant tipping and space loss are occurring. Coming to some space regaining procedures. In the maxillary arch, space regaining procedures are generally space is easier to regain in the maxillary arch than in the mandibular arch because of the increased anchorage for removal appliances afforded by the palatal vault and the possibility for use of extraoral force from the headgear, which is not possible in the mandibular arch. Permanent maxillary first molars can be tipped distally to regain the space because the molars tend to tip forward and rotate mesolingually. So the distal tipping will regain 2 to 3 millimeter. That will be satisfactory to correct some of the amount of malocclusion. Space requirement. A removable appliance retained with Adams clasp and incorporating a helical finger spring adjacent to the tooth to be moved is effective for this procedure. One posterior tooth can be moved up to 3 millimeter distally during 3 to 4 months of full-time appliance wear. The spring is activated approximately 2 millimeter to produce 1 millimeter of movement per month. Here in this picture, a removable appliance with a finger spring can be used to regain the space by tipping a permanent first molar distally. Here, the permanent first molar has been tipped mesially, and this is an appliance with a finger spring, which will lead to this molar in the distal direction. And this removable appliance can be used to regain up to 3 millimeter of space. After space regaining, the space should be maintained with a band and loop or lingual arch if the permanent incisors have erupted. For unilateral bodily space regaining, a fixed intra-arch appliance is preferred. The excellent anchorage provided by the remaining teeth and palate can support the forces generated by a coil spring on a segmental arch wire to produce distal movement of the molars only on one side with a good success. Here is a fixed appliance can also be used to regain space in the maxillary posterior region with the coil spring generating the distalizing force. This is the occlusal view where from the premolar to molar there's compressed coil spring is given that will drift the molar in a distal direction and give some space regain in the maxillary arch. And here this is the Nance button, which is used as a palatal anchorage to for the application of this, to assist in the application of this closed coil spring appliance. If bodily movement of both permanent maxillary first molar is necessary in regaining space, this can be accomplished by using a banded and bonded fixed appliance or headgear. An asymmetric face bow with a neck strap attachment can be used. Asymmetric cervical headgear is neither as easy to adapt nor comfortable. In the mandibular arch, for unilateral mandibular space regaining, the best choice is a fixed appliance and an arch wire which provides excellent anchorage. Lingual arch can be used to support the tooth movement and provide anchorage when used in conjunction with the segmental arch wire and coil spring. Moving the molars distally in the mandibular arch is challenging and requires support from a number of teeth. Using a lingual arch to incorporate anchorage from the permanent and primary molars as well as the incisors and force from a coil spring can be effective for space regaining. If space has been lost bilaterally and there are two choices, short of bands and brackets, an adjustable lingual arch and a lip bumper. The idea is that the appliance presses against the lip, which creates a distal force to tip the molars posteriorly without affecting the incisors. And this lip bumper is constructed from the 36 gauge stainless steel wire bow with an acrylic pad, and which will fit in the tube into the first molar. It's sometimes used to increase the arch length also, because this occurs when the appliance stretches the lower lip and transmit force to move the molars back. The appliance also disrupts the equilibrium between the lips and tongue and allows the anterior teeth to move facially. This result is nearly equal molar and incisor change. Thank you. These were the some interceptive measures that should be taken during the interceptive orthodontic procedures. Remaining measures will be taken in the next video lecture. Thank you.